both in the room and of course online. So today we're having a special kind of statistics seminar, in the sense there is probably going to be very little statistics. But what we thought is that we hope that the topic is somehow touching everyone and is speaking to everyone in the room and online as well. So it concerns social epidemiology, and I'm very glad that Professor McMunn decided or accepted our invitation. So as said, she's an expert in social epidemiology, and she has studied a lot of social determinants of health. And today she's going to talk about gender gaps in unpaid care work. But probably I should leave the room to the speaker.
Thank you, Alessandra. Right, yes, thank you very much for inviting me. As Alessandra said, I'm Anne McMunn. I'm a social epidemiologist in the Department for Epidemiology and Public Health here at UCL. And for about 20 years, I've been working in an ESRC-funded research center that focuses on life course social epidemiology. So we tend to use quantitative methods in the UK's large longitudinal survey investments to study the social determinants of health from a life course perspective. And I'm going to start my talk just giving a little bit of background about that work, the work of our department, and then lead into the topic of interest today, which is unpaid care work as a social determinant of health and gender differences in unpaid care work. So as Alessandra said, I'm not a statistician, and this is not probably like the normal statistics seminars that you'll be having. I don't have any equations. I'm barely referring to the methods that I've used in this work. I'm really providing an overview of the results of some of the studies that we've done so far. But maybe if you are interested in the methods or have any advice, statistical advice about any of the work in the discussion afterwards, that would be fine too. So yeah, I think really Alessandra invited me, as she said, just thinking maybe broadly about gender inclusion and inequality in STEM subjects and in our departments in which we work, and maybe reflecting on the role of unpaid care work and how that might influence some of the gender outcomes that we see in the workplace. So just starting with a bit of background about the work of our department, it's really very much grounded in this idea of health inequalities. Our department at UCL is very well known for our work on health inequalities research and has been for many decades. So the UK is actually a world leader in this topic, I would say, going back to 1980 with the Black Report was the first government report on this topic. And we've had several reports since which have been led by members of staff here at UCL. So the Atchison Report in the 1990s when Blair came in, and then reports by Michael Marmot more recently. You may have come across Michael Marmot. He is in the news quite a lot talking about these topics. And this is just an example of one of the graphs that from one of Michael's reports that he uses quite a lot to illustrate health inequalities in the UK. So this is showing life expectancy, which are the gray dots, and disability-free life expectancy, which is the green dots. And along the x-axis, we have neighborhood deprivation. And the green line going across is state retirement age, state pension age, which is kind of shifting upwards from 65 to 67. And the point he's making here is that in the more deprived neighborhoods in the UK, you can see that on average, people are reaching disability long before they're actually even getting to state pension age. So inequalities in health. And really, Michael made his name in this field from the Whitehall studies, or the Whitehall 2 study in particular. And this is called the Whitehall study because it's a study of British civil servants. And he chose civil servants because the UK civil service is very hierarchical in terms of its staffing grades. So it seemed like a good place to study inequality in terms of hierarchy. And really, one of the main findings that comes out of this work is that it isn't simply people who are living in deprived circumstances or in poverty where we see worse health. We actually see this gradient so that, for example, in the civil service, with each kind of reducing grade, staff grade in the civil service, we see an increased risk in poor health outcomes. So here we're looking at CHD mortality. These are the early studies from the Whitehall 2 coming out in the late 70s. So that it's more of a graded association with decreasing sort of staff status. We see increased risk for poor health outcomes. And they went on to show that actually very little of this gradient is explained by classic health risk factors like smoking, cholesterol, blood pressure, the things that we all think about in terms of health risk. And this led them to be interested in what they called then and what we still call the psychosocial risk factors for health. So the idea here is that there are stressful stressors in our environment. In this case, they were very interested in the work environment that might trigger stress responses biologically that then over time can influence people's risk of chronic disease. So this became a huge area of work, and we've had 45 years now of both theoretical and empirical scholarship looking at work and health, thinking about psychosocial risk factors at work and health. Some of the big models that were developed I've shown here. So one called the job strain model by Karasek, which is talking about the amount of control that people have over their working lives or their working days and the demands that they have at work. So if you have a low control, high demand job, you're more likely to end up with cardiovascular illness. And particularly control at work seems to be quite important. And we also have this idea of effort reward imbalance. So the reciprocity between the effort that people are putting into their work in relation to the rewards that they're getting out. So decades of work on this, a real body of evidence now. This is an example of a meta-analysis that was done by our colleague Mika Kivimaki over a decade ago, pulling together studies looking at job strain, so that's that control demand model in relation to onsets of coronary heart disease. And we have a really well-established body of evidence now. And I'd say that we have a good evidence base around these stressors or aspects of job quality in particular. So the demand control model and the effort reward imbalance model that I've mentioned, but also job security, somewhat on flexibility of work as well, although that evidence base is less developed, and long work hours and low pay as well as what we would call social determinants of health, psychosocial risk factors for health at work. So thinking about this body of evidence, really this is just to say we have all this scholarship on work and health, but if we're thinking about this from a gender perspective, we know that over the past 40 years or so, women's participation in the labor force has continued to increase, but women still have unequal access to these high quality jobs that we now know are associated with better health outcomes. So we continue to have gender inequality in labor market outcomes. We know that women are still less likely than men to access the labor market fully, so they're less likely to work full time. Average work hours for men currently is 35.3 hours per week. For women, it's 27.8. We continue to have a gender pay gap in the UK and elsewhere, and women continue to be underrepresented in positions of power, both in terms of government positions, but also in the commercial sector. And we know that women are overrepresented in sectors that are characterized by low pay and precarious working conditions. So we continue to have this gender inequality in labor market outcomes. And I guess one of the questions is why? Why is this persisting? We're pretty sure it's got nothing to do with human capital. So men and women leave full-time education at least on an equal footing. Actually, women do better than men now, largely in terms of university degrees, for example, in the UK, US, and elsewhere. And men and women seem to be ticking along pretty equally until one particular life course transition, and that's the entry to parenthood. Oh, yeah, sorry. So just coming back to, oh no, I got a bit sidetracked there. Yeah, so one of the things that we think may be driving this is unpaid care work, which I'm going to talk about in relation to the entry to parenthood. But just to highlight a few reports that have come out arguing that unpaid care work is what they've called the missing link in terms of understanding these gender differences in labor market outcomes. So this OECD report 10 years ago highlighted unpaid care work as the missing link in labor market outcomes. And more recently, the Women's Budget Group in the UK put out a report arguing that unpaid care work is at the heart of gender inequalities in the UK. And I published this commentary in Lancet Public Health last year, where I argued that we have this vast body of evidence about employment and job quality in relation to health, but we really have very little scholarship on unpaid care work at all. So there's this whole other aspect of work that is not being studied really very much at all. So when I talk about unpaid care work here, I'm referring to all of the unpaid services that are provided within a household or a family, sometimes in the community as well, for its members. So we're talking about care, we're talking about childcare and adult care, but we're also talking about things like housework. These are all aspects of work that are provided unpaid within the family. And we know we have gender differences in unpaid care work. And we know that parenthood and entry to parenthood seems to trigger those differences. So this is one example. It's a bit old now, but it's very visual, so I like to show it. But it really represents a body of work showing that men and women are pretty equal when it comes to work and unpaid care work until they enter parenthood. And this seems to trigger a kind of reset in gender relations within couples. So this is time use data in the British Household Panel study, where Pia Schober looked at the time that couples spent in housework and in paid employment in the years leading up to the birth of their first child, and then the years subsequently. And she showed that they were pretty equal in the years leading up before becoming parents. Women did a little bit more housework than men and a little less paid employment. But upon the birth of the first child, women's employment hours plummeted and their housework hours went up a little bit. And this continued for a few years after the birth of the first child. But really, she didn't see any difference in men's hours in employment or housework. And in fact, some studies show men's employment hours actually increases when they become parents. So that's a little bit old now. More recent, this is just cross-sectional snapshot using the labor force survey, looking at employment by gender, age, and whether or not people are parents. So you can see amongst those who do not have dependent children at home, that's the turquoise bar for men and the green for women. Gender differences in terms of employment are minimal. But when we look at parents, we really see that difference open up, that fathers are employed at much higher levels than mothers are, particularly at these younger ages when people have young children at home. So really what we're talking about here isn't so much a gender gap, but more of a motherhood penalty. And that's been talked about a lot in relation to the gender pay gap, that really we're largely talking about a motherhood penalty. This is an example of that that was highlighted by in The Economist in 2019. And really using a similar technique to Pia Schober's in terms of time use, but this is earnings in the years leading up to entry into parenthood. and then the years subsequent across different countries. And you can see that in terms of earnings, men and women are pretty darn equal in all countries until they become parents, and then women's earnings drop off really everywhere. There are differences in magnitude across countries, but the drop for women is consistent there, and we don't see that for men. So we wanted to look at this in more recent couples in the UK. Pia Schober's work in the BHPS was a little bit old now. And I think this was the study that Alessandra's mother noticed in Italy and told her about, which is why I'm here. I don't know if you might be familiar with the BHPS and the UKHLS. The UK Household Longitudinal Study is a more recent version. And so when this was established, we looked at how men and women couples, because it's a household survey, we can look at couples. And we used latent class analysis to look at how they shared or didn't share for different types of work. So paid work, housework, adult care, and child care in the second wave of the UKHLS. But before I show you the latent class analysis results, I just want to show you how those different labor forms sort of broke down across couples. So we had paid work, housework, childcare, and adult care. And the red bars are where men are doing more than women. The turquoise bars are where they're sharing pretty equally. And the yellow bars are where women are doing more than men. And the blue bars are where neither are doing very much at all. So you can see in paid work, it's really the only work form here where large numbers of men are doing more than women. So we have about 45% where he's working full-time and she isn't, but also a high proportion of couples where both are working full-time, about a third of couples. But when we look at housework, we see a very dramatic difference in terms of sharing and not sharing. So the majority of couples, 55%, women are doing more than men. And only in about 16% of couples are they sharing equally. A large portion of our couples didn't have dependent children at home, a little over half. About 27% women were doing more childcare. Mothers were doing more childcare than fathers, and about 18% they were sharing equally. And a minority of people are providing adult care. A little under 3/4 are not providing adult care. But we have sort of fairly equal numbers here, about 12% where women are doing more adult care, but 18%, no, 10% where they're sharing pretty equally. So we put these into the latent class analysis, and we came up with these groups, and I'm not going to go through all of them in detail. It's too much to do. But I just want to highlight that the green pieces of the pie are couples. They're different types of dual earner couples. So where both are working full time. And this largest portion of couples, 36%, tended to be younger couples. So they were these kind of millennial couples that we were trying to capture because we were interested in whether the millennials were sharing more equally than previous generations. They tended not yet to have children at home, and they weren't providing adult care. So they had low levels of care, both working full-time, tended to be younger. The blue pieces of pie were couples, different types of more traditional male earner couples. And then we had the gray pie where neither member of the couple were working full-time. The 5% red pie was where women are working full-time and men aren't. And this tiny 1% peak piece of pie where men in those households are doing a lot of unpaid care work. So we then looked at these by the different labor types within them. So this is housework hours for each of those groups. And this top group here, dual employed, low care, is that 36% light green piece of pie, those sort of millennials that we were interested in. And we're looking at housework hours here in terms of what men and women are doing within those couples. The light blue is less than 5 hours of housework per week. The sort of turquoise is 5 to 9 hours. The darker blue is 10 to 19 hours, and the black is 20 hours or more. So you can see that across these different couple work types, in almost all of them, women are doing more housework than men. It's only in this 5% group, that red group, where women are working full-time and men aren't, where they start to approach equality in terms of housework. And this 1%, the pink pie, where men, all of the men in that group are doing 20 hours or more of housework. But otherwise, women are doing more. And even in this sort of dual earner millennial group, we see that women are doing quite a bit more housework than men. So about 45% of men in these couples are doing less than 5 hours of housework per week, compared with about 11% of women, whereas about 2/3 of women in these couples are doing more than 10 hours per week, compared with less than a quarter of men in these couples. So the kind of take-home message that the media picked up here in relation to this story is that even in these younger couples that aren't yet parents, we are seeing gender differences in terms of housework. So we also looked at this during the pandemic, because you may remember during that first lockdown, there was a narrative going around that, okay, now both mothers and fathers are working at home. They're having to manage childcare at home. They're having to manage homeschooling. Maybe this is when we start to see more equal division of labor at home. And lucky for us, the UK HLS did some COVID collections and collected information on this. And what we found is that actually, this is in April and May, so during that first lockdown, men did do more, so they were doing more hours of childcare and housework, but women were as well. So actually, the share that women were doing was equal to what it was prior to the pandemic. So when we look at childcare and housework, women do about 2/3 of hours within couples, and that was equally true before the pandemic. In May, we also asked them to include these questions about, for working parents, are you having to reduce your employment hours or adapt your work patterns to accommodate childcare and homeschooling? And you can see that both mothers and fathers are having to do that, but mothers are doing more of it than fathers. Okay. I think that's all I wanted to talk about in relation to gender and unpaid care work. And now, because I'm a social epidemiologist, I want to come back to the question of health a little bit. I'm just going to touch on the very small amount of evidence we do have in this area, and it is very small. As I said, it really hasn't been a topic of focus in social epidemiology. But I think of this in terms of kind of two possible ways. One is what I'm calling a direct association, in the sense that there might be aspects of unpaid care work, like there are aspects of paid employment that influence people's health. But we can also think about unpaid care work influencing health through the way that it's restricting people's access, and particularly women's access to kind of high quality employment. So just taking the first, thinking about direct mechanisms. So as I mentioned, we know that things like low control and high demands, low pay, in this case, no pay, lack of flexibility and long work hours are associated with health in relation to paid work. And we know that these are also things that may characterize unpaid work, unpaid care work as well. But we should also recognize that there may be rewards attached to unpaid care work as well, sort of psychosocial benefits in terms of potentially feeling appreciated or stronger relationships. Those kinds of things have been talked about. But as I say, very little work has directly looked at this as a kind of risk factor for health. I think this is the best study I've seen on this, and this is work using HILDA, which you may be familiar with. It's the Australian version of our UKHLS. So again, a household panel study. And they used fixed effects to look at housework, childcare, and other care, which is largely adult care, as well as outdoor tasks in relation to changes in mental health functioning, both the sample combined and men and women separately. And then they also combined those different forms of unpaid care work to look at total number of hours. So I forgot to bring my glasses, but hopefully I can see those numbers. What they found was in relation to housework, increased hours of housework were associated with reduced mental health functioning, but more so for men than for women. But when it came to childcare, there was a more obvious gender difference. So increased hours of childcare were associated with improvements in women's mental health, but not so in men's. In terms of adult care, increased adult care hours were associated with reductions in mental health, more so for women, although the gender interaction term is pretty large. This, as I showed in the other work, is a less common form of labor, so it's a smaller group, so doesn't kind of reach statistical significance there. And in terms of outdoor tasks, doing more outdoor tasks was associated with improved mental health for men and not for women. So really a very traditional gender picture coming out here, where childcare looks beneficial for women and outdoor tasks looks beneficial for men. And the authors do talk about how the sort of culture around gender in Australia still is a little more traditional in terms of social norms and behaviors than it is in some European countries, for example. So they speculate that it might look different in other countries. And we have yet to replicate this in the UK. Before this study came out, we did look at trajectories in mental health using growth curves in relation to housework and childcare at baseline in the UKHLS. And we actually did not find any association once we accounted for mental health at baseline. So we interpreted that as potentially a selection effect, where it may be that people who had better mental health prior were then doing more childcare. We haven't published that yet, but I think this is a real, there's a lot to be done here that really hasn't been done yet. We did look during the pandemic at some of that data I was showing you on men and women, mothers and fathers doing childcare and homeschooling and housework during the pandemic, and how that was associated with GHQ score, which is a measure of psychological distress. And we found that particularly parents who reported having to adapt work patterns due to homeschooling and childcare did see higher levels of psychological distress during that first lockdown. But when we look by partnership status, we see that actually for women, that association is really entirely being driven by lone mothers. So lone mothers who were having to juggle homeschooling, childcare, and employment during the first lockdown saw a real spike in psychological distress symptoms. And we then see that going through the pandemic in January, then where we had that second lockdown and schools being closed, we see the same spike for lone mothers during that time. The area where there has been a little more work done is around providing adult care. So the health of carers providing adult care. A lot of the work in this area has been done on small clinical samples, so largely people who are providing care to dementia patients. But there is more and more kind of population level survey work coming out on this. This is a project that we had looking at care and health, again in the UKHLS, where we found that particularly women under the age of 45 who were providing care tended to have worse health outcomes, both in terms of mental health, but also in terms of adiposity. So here we're looking at BMI, waist circumference, and percentage body fat. So in epidemiology, we're quite interested in waist circumference because visceral body fat is a real risk factor for cardiometabolic outcomes in the way that general BMI isn't as much. So we do measure these in a lot of our social surveys. So we found that across these different health outcomes, it was those women, younger women providing care to adults, which tended to be parents, but wasn't always parents, who ended up with, or who had poor health outcomes. Since then, we've had a study called Eurocare, which just finished this year, where we were looking at associations between providing care at different stages of the life course in relation to health outcomes. And it was a kind of cross comparison across different European countries. But this is work that we again did in the UKHLS, looking at providing care at different sort of life stages. So under 30, 30 to 49, 50 to 64, and 65 plus. And here we're using piecewise growth curves that are centered around the transition to providing care. So these are trajectories in GHQ score, psychological distress, in the waves leading up to identifying as a carer, around the transition to care, and then the waves after becoming a carer. And we are looking at this by intensity of care as well. So the green lines are non-carers. The blue lines are those caring for less than 10 hours per week. And the red lines are people caring more intensively, 10 hours or more per week. And we've matched non-carers with carers using propensity score matching here. So what you can see around that transition to care is an uptick in psychological distress symptoms across all of the ages, but it looks to be larger in those kind of middle age groups. And it also sort of begins in those waves prior to identifying as a carer. So we speculate that maybe family members are starting to become unwell or losing their functioning, and people may be starting to take up some care activities potentially, but not yet identifying as a carer. And then we also see that the difference between those caring intensively and those not persists after making that transition to care for at least several years. We're not modeling exits from care here. So this is just the transition into care. Okay, and we've also done some work as part of that project around this idea of sandwich care. So sandwich caring generations, looking after dependent children, but also adults at the same time. In the UKHLS, we find that only about 4% of people in the UK are simultaneously providing care to dependent children and adults. And only about half of those, so 2%, are providing care to a parent or grandparent or in-law, someone in the generation above. So that kind of traditional idea of being sandwiched between the generations. The other half are providing care largely to disabled partners or disabled adult children. And people in that group are really caring very intensively, and it has a big impact. But we conducted the same analysis that I've just shown you with the discontinuity models and the propensity score matching amongst parents of children under the age of 16, then looking at entry into adult care compared with parents who don't enter into adult care. And again, we see an increase in psychological distress symptoms for both mental and physical health functioning for mothers, but less so for fathers. For fathers, we do see it with mental health when they're caring quite intensively at 20 hours per more per week. But otherwise, we see it for mothers only. Okay, and I just want to touch briefly on this idea of unpaid care work as potentially influencing health through its restriction on people and generally women and mothers' ability to participate fully in the labor market and access those high quality jobs that we know are associated with better health outcomes. So the idea here is that we get financial benefits from working in decent quality work, but we also get other more psychosocial benefits. This is going back to Yehuda's 5 functions of employment idea. So things like having a time structure, having those sort of social contacts at work. Some of us learned how important that was during lockdown, that kind of, getting out and seeing people as part of the employment experience. Having collective kind of goals and purpose outside of your own family. And in our culture, work provides us with a real sense of identity. It's one of the first questions we ask people about themselves, and it can provide status as well. So the idea here is that because of their greater unpaid care work load, that women have unequal access to both the financial and psychosocial benefits of high quality employment. On the other hand, we also know that now with busy working parents, that sort of time reservoir that used to happen within families when we had housewives has gone. And so does that mean there's more stress? People are trying to juggle more, and does that stress fall more on mothers than it does on fathers? So this is kind of going back to that old role overload or role strain hypothesis that you may have heard of, that kind of emerged in the 1980s and 90s as mothers were starting to enter employment more generally. And at that time, there was a lot of cross-sectional survey work done, which showed that women who were combining employment with marriage and parenthood did tend to have better health. This was always self-reported health at this stage than women who weren't. But because it's cross-sectional, of course, we don't know if combining those roles is leading to better health, or if women who have better health earlier on in the life course are more likely to take up those roles. So there are 2 studies that were kind of trying to update this work from a life course perspective, using multi-channel sequence analysis to characterize work-family life courses. And these, both of these studies happened at the same time virtually as a coincidence. One was led by myself here in the UK using the British birth cohort studies. So these studies that we have in the UK that follow people from birth until death. So here we're using cohorts born in 1946, 1958, and 1970. And then work by Lisa Berkman's group at Harvard, where they were doing using the same technique in the Health and Retirement Survey in the US. And we actually found remarkably similar findings, which the gist of which overall is that women whose life courses were characterized by longer periods of time spent out of the labor market, looking after the family, were more likely to be depressed in mid to later life, reported lower life satisfaction, worse health, had higher BMIs, had higher levels of inflammation. So as epidemiologists, we're interested in inflammation as being on the stress response that people have in relation to chronic stress, and also potentially being linked with chronic illness. So possibly on that pathway between stress and health, and also to have worse metabolic profiles. So things like blood pressure, blood sugar, triglycerides, fats circulating in the blood. And the US group also looked at mortality and found that women in these groups died younger. So yeah, a body of work there that I'm just high level characterizing. I'm not going to get into any of the detail because we don't have time. So I'm going to skip through a few slides, but we can come back to it if you're interested. So I just want to finish by just very quickly mentioning a couple of things that we're doing currently around sort of policy areas that are relevant to this topic. So flexible working and parental leave. In terms of flexible working, my colleague Bao Zhu is working on a fellowship using difference in difference methods to look at the impact of the 2014 policy on flexible working that gave employees the right to request after 26 weeks of employment, and to look at the impact of that on uptake of flexible work. Again, this is in the UKHLS. And she found that the policy reform did slightly increase use of flexible work for women, but not for men. She's then gone on to use fixed effects models to look at associations between uptake of flexible work and a range of outcomes. And she's found that the uptake of flexible work is associated with increases in housework hours for both men and women. So people are using flexible work to do more at home. But this is more true for women than for men. So if you actually look at the share of couples, in those places where women have taken up flexible working, their share of the housework is greater than for men. So it suggests that actually that flexible working is increasing gender inequality in terms of housework, potentially, if anything, in that context. But she also finds that uptake of flexible work is associated with decreased psychological distress and improved mental health functioning for both men and women, and doesn't find any association with life satisfaction or satisfaction with leisure time. So kind of mixed bag there in relation to flexible working. And this is work that we have just been doing in the Millennium Cohort study. So this is the cohort of kids born around the last turn of the millennium that have been followed up to age 23, looking at fathers taking paternity leave and the longer term associations with a variety of outcomes. Early studies at sweeps 1 and 2 showed that fathers who took up paternity leave were more involved with their kids at 9 months and at the age of 3, and we wanted to see whether that persisted over the longer term. And so that's what we have here. So I guess one thing that's important to say is this is before we had any statutory paternity leave in the UK. It came in just after this study started. So fathers in this study who took up paternity leave were fathers who were in advantaged jobs that had access to paternity leave through employment. So we are looking at paternity leave, which is the blue line, and also other forms of leave, because a lot of fathers then took annual leave effectively at the time of birth, and that's the red line. The green line is fathers who didn't take leave, and the yellow line is fathers who weren't employed at the time of birth. And this is modeling trajectories in fathers' involvement up to the age of 11 at the end of primary school. So you can see at 9 months at sweep 1, there's a small difference here. So fathers who took up paternity leave are a little more involved than fathers who didn't. But we see over time that actually both leave-taking groups, fathers are more involved throughout the primary years compared with fathers who didn't take any leave at the time of birth. For those who weren't employed at the time of birth, they have the highest levels of involvement at 9 months, and then that drops off over time. We are adjusting for time-varying fathers' employment here, so this shouldn't really be capturing entry into the labor market for those fathers, but yeah, we can't really explain that. There's something going on there. We've also looked at this in relation to other outcomes like the children's socio-emotional development. We don't see any association there. We don't see associations with parental mental health, but we do see associations with relationship quality between the couples, both for the men and the women. But it wears off by about the time the kids are 5. Okay, and I'm just going to leave you with this. This is from the British Social Attitude Survey, where people are asked how parents should divide the leave taking at the time that children are born. So you can see in 2018, 40% of people in this survey thought that mothers should take most of the leave, but fathers should take some. And another 34% thought that mothers and fathers should split the leave equally. But uptake of shared parental leave in the UK is really very, very low. It hovers around 2% each year, sometimes gets up to 5%, maybe 8%. It's just not being taken up. So I guess a question for you that I like to think about is, why do we think it'd be a good idea for mothers and fathers to share leave, but we're not doing it? And I guess I think this is quite important because we've seen that entry into parenthood is what is really associated with the labor market outcomes for mothers in particular. So if we want to shift that, I think this is where we need to start. And I think that's it. Thank you.
Thank you very much, Anne.